Merci, Dr. Roy, pour l'introduction. Comme vous avez entendu, je viens de North Bay, alors c'est toujours un plaisir comme franco-ontarien de revenir chez moi. So you'll notice I don't have a PowerPoint. This is a deliberate choice. It's not a technical failure like most conferences. I think in healthcare that the most important thing we do in healthcare is communicate, is talk and listen to each other, and I think we should be setting the example by doing that. So I'm just going to talk and hopefully leave enough time so that you guys can get in your 2 cents as well. Comme il n'y a pas de traduction simultanée ce soir, je vais parler principalement en anglais, mais je serai content de répondre des questions dans n'importe quelle langue. So before I wade into the topic, I'll give you a quick sense of what I do. As you heard in the introduction, I'm a journalist. I'm not a physician or a nurse or a health economist or any of those other fancy things, but I've been hanging around the health system for a long time, about 30 years now. I have the point of view of an outsider. That's what I'm going to present tonight, and the point of view of a consumer. That's my approach to writing. And I see my job as a journalist to be an observer and a translator. I take all the medical mumbo-jumbo and translate it for patients and the general public, and try and give them a sense of what the health system does and doesn't do. The big advantage I have as someone who works for a big newspaper is I have quite privileged access to the system. So I travel all over the country and all over the world to get a sense of how systems operate and to compare them. A health system is really a big puzzle, and people don't always understand how the pieces fit together. And that's what I try to do, to help them navigate the maze. And that's really important now because people are more and more hyper-specialized within the system. So that's the introductory stuff. Now on to my challenge. What I did is I took Dr. Roy's passing suggestion and I took it to heart. I said, you know what I'm going to do? I'm going to critique the strategic plan for them tonight. He essentially said to me, well, tell me what you think of it. He also said, just say the good things, but I dropped that part. So you don't have to ask a journalist twice to give a gratuitous, semi-informed opinion. So that's what I'm going to do tonight. So let me start with my headline, my one-word review of the plan. The word I came up was refreshing. I think it's refreshing to see leaders of an institution actually articulate a vision and articulate goals clearly. We don't have enough of that in Canadian healthcare. And it's doubly refreshing to see the plan out there for public consumption and welcoming feedback, even from someone who you don't know what they're going to say, and you should be worried. So, we don't have that kind of dialogue and openness near enough in Canadian healthcare. So I think you're setting a really good example. And in fact, it speaks to one of my pet peeves. One of my big pet peeves about Canadian healthcare is that we don't have any goals and we don't really have a vision. And the best way to illustrate that is with a question. And I'll ask you guys a question. Does anybody in the audience know what the mission statement of Medicare is? Medicare is really important. Canadians love it. What's its purpose? What's its mission statement? Anybody know? Great, you're all right, 100%, because there is none. So you're all 100% right, you passed the test. And that's sad. We really should have the really concrete goals. The de facto mission statement we have is to just spend as much money as we did last year, and maybe a little more, but not too much more, and do the same thing. That's not a very good vision. People often ask me, I get asked a lot of tough questions about healthcare, and one of the most frequent ones is, do we spend enough on healthcare, or do we spend too much, depending on who's asking you? And my answer is, sadly, it's always the same. My answer is, I don't have the slightest idea, because I don't know what we're trying to do. What are we trying to do ultimately? I'm not sure. We'll spend in Canada this year $211 billion, $6,000 per person, on healthcare, and there's not really an end goal except to spend all the money and to hear people complain that it's not enough. In its last budget, the province of Ontario actually set a goal, but the goal was this. It was health spending will not exceed 2.1% increase next year. I didn't find that personally very inspiring. I don't know about you guys, but to me that's not a vision. That's an accounting exercise. That's not the way you run a health system. The way to spend responsibly and appropriately is to have goals and then invest in achieving those goals. That's why a strategic plan is ultimately really important. Now, I've been harping on this stuff for a while, So a lot of people challenge me. They said, oh, you talk about this. Well, why don't you come up with a vision statement? So I came up with something pithy, and I'll tell you what I came up with. I came up with the purpose of Medicare is to promote good health, alleviate pain and suffering, restore health and extend life when possible, and ensure a good death for all Canadians. Now, I don't think that's perfect, but it's just an idea I'm throwing out there. It's all motherhood and apple pie, but I think that's what you need as a vision. Really some grand goals. The point is that a smart, sustainable business has to have a mission and know what it is and aim to achieve it. You can't just have financial targets. That's not what's important, and certainly not what is important to Canadians in Medicare. So once you have that grand vision, you set specific goals. So I'll give you an example. I think Canada should have a goal to reduce child mortality from 5.7 per thousand to 2.3 per thousand, which is the rate in Finland, the best in the world. So I think that's an achievable goal, a doable goal, and then you invest in it and you say, if we don't meet it, somebody has to be held accountable. That's how you run a good health system, and we don't do enough of that. We have vague goals, and that's not fair and it's not smart to know what we're doing. I think we should be rewarding and emulating leaders who set goals and meet them. And again, that's the way they're going to get achieved. So let me bring it back to the local level. So that was my little rant about lack of vision. I think what is really impressive with the plan you've put together is that you've got all the important stuff in there. So you've got the mum and apple pie stuff that I talked about. And we take that stuff for granted, but it really is important because Medicare should be a reflection of our values, of our collective values. This belief, which I think most Canadians have, that we should care for each other as much as for ourselves. And that's really important to articulate. And we shouldn't be ashamed to talk about it and to be proud of it. So let me read your mission statement. I'm sure you've all read it and you've memorized it, but I'll refresh your memories. So it starts like this: our mission, to improve the health of Northerners by working with our partners to advance quality care, education, research, and health promotion. So it touches on all the big issues. Our vision, globally recognized for patient-centered innovation. That's pretty bold, that's good. And our values, excellence, respect, accountability, and engagement. Again, almost perfect. I think you should take that stuff and put it on a brass plaque at the front door. And I don't say this as a joke, I say it quite literally. The big companies that I visit, when I visit companies like Medtronic and Amgen and Johnson & Johnson, all the successful companies do exactly that. Their mission statement is right at the front door, and it's in brass, and it's there for the world to see. And we need to do that in Medicare. So once you have these big goals, you have strategic priorities to back them up. And again, you have a good set of them. 3 priorities. Excellence in evidence-based care, being innovators, and being leaders in care transition. And again, you could quibble with the choices, you could quibble with the wording, but I think it's important that this not be a nitpicking exercise. You have to look at the big picture. And I should note that a lot of institutions don't get to where you've got because they get bogged down in all the wordsmithing and the debates about the order of things, etc. So I think it's great that you've actually got stuff on paper and you're starting to act on it. That puts you way ahead of a lot of other institutions. So what I really like about the strategic priorities is that they're also aligned with your business plan. And again, we often forget to do that. You've understood, I think, one of the most important lessons in goal setting. If your priorities don't have dollars attached to them, then they're not really priorities. They're just pipe dreams. So it's really important to have that alignment, so those 3 steps. So I want to spend a little bit of time, the time I have today, going through each one of these priorities and sort of muse on how they fit into the larger system. So number 1, excellence in evidence-based care. The other question I get often is this one: what do patients want? The ever-elusive question. And I, again, have tried to boil this down, the answer to a single sentence. I think they want care that's safe, accessible, appropriate, affordable, and respectful. That's a lot to achieve, but I think we have to deliver. They also want a system that's fair, a system that's equitable. It doesn't mean everyone gets exactly the same care, but everyone gets necessary care and within reason. There's limits to what a public insurance plan can cover. We know that. But one of the things we do the most badly in our health system in Canada is we don't know how to say no. And you have to be clear on what you cover and what you don't cover. And we don't do that. And that, again, misleads people. You have to really draw those lines in the sand to ensure that we get value for money and to ensure that the greatest number of people get the most care. And the way to do that, there's only one way to do that. And you've understood that in your priorities. It's to do it with evidence. Now, you might think that's self-evident. Well, we should only pay for what works. But that's not the reality in healthcare. The reality in healthcare is something quite different. We do things for all kinds of reasons: tradition, wishful thinking, politics. Those are not usually very good reasons. By all estimates, and there's been a lot of research on this, about 25 to 30% of care actually provides no benefit or provides harm to patients. That's a lot of harm, about $60 billion worth in Canada a year. It tells us we could do things quite a bit differently with the same money we have. And on the local level, if you do the math, it's about $90 million worth of care that's probably not doing a lot of benefit to your public, to your consumers. So think of how you could spend that money differently. Now, identifying not so beneficial care is not always easy. I don't pretend it is. But evidence has to be your friend. You have to really embrace evidence. And Canada is actually a pioneer in the field of evidence-based medicine. And other people have used it much more than we do. We're good theorists, we're not so good at the practice. Number 2, innovation. So we talk a lot about innovation in the goals. And that commitment is important. But innovation isn't all about just buying new technology. What you want is innovation in service delivery. And again, I like that focus in the strategic goals. I can't stress how important that is. In Canada, I think we deliver excellent medical care. And it's really important to say that publicly and to say it out loud, because we forget that. Satisfaction scores in hospitals are really high. I think they're about 95% here. And it's true, once you're in the system, you get tremendous care. Now, the access is lacking, the transitions are problematic, but once you're in there at the right place, we're second to none. So what I'd like to say is in Canadian healthcare, our problems are not medical problems. They're actually engineering and administrative problems. That's where we really need the innovation. We need to fix the processes of care, what people call the patient journey, if you will. And we have to get our priorities straight. I think if you ask any patient in a hospital what matters, and I visit a lot of hospitals, I talk to a lot of patients, I think what they'll always tell you is it's the little things that really matter. They don't care about, if the MRI was built in 2008 or 2011. They care about the personal touches. The doctor who puts down the clipboard and actually looks them in the eye, or the nurse who holds their hand late at night, or the member of the cleaning staff who says, hey, is there anything I can help you with? That's the stuff people remember. They don't remember anything else, to be honest. And that's the innovation we really need, I think. This innovation of embracing a culture of engagement, of valuing relationships. And that's what healthcare has been about for millennia. And we've kind of lost touch with that, with a little too much technology and too much dependence on technology. As I mentioned, I visit a lot of healthcare institutions all over the world. And I can usually tell within a couple of minutes whether the care is good. And I don't have to go into surgery or anything. I just have to walk around the halls. And you get a sense of it from the workers, from the pride of workers and the faces of workers. If people look you in the eye, that makes so much difference. And I can't emphasize how much that little stuff matters. The other thing I notice in really good healthcare institutions where care is good is the engagement of management and administration. Administrators who walk around the wards every day and get feedback and act on it. You can't stress how much that makes a difference. If a nurse points at a problem and it gets fixed, word of that gets around really fast and it really boosts morale. There's much more engagement and embracing of it. And that's the whole philosophy behind the lean management concept, which you've probably heard of. There's a lot of talk about it in healthcare. But all that to say, the most important resource we have in healthcare is people. And if you want to innovate, you have to tap into the knowledge of the people. There's so much there to be garnered, and again, we don't do it. We don't listen very well. So the third, the final strategic priority is being leaders in care transition. And again, when I read that, my first thought was, well, amen. That's really something that has to be underscored with a bold highlighter. Because healthcare is a risky business. A lot of bad stuff happens. And all the bad stuff happens in transitions. And we forget that. As I said before, when you're in the right place, you get good care. But we move people around, and that's when all the bad stuff happens. Again, anyone who's had a loved one in the system knows that. When you move from the ER to the ICU, from the ICU down the hall, when you go home to home care, that's where all your bad things, where things go wrong. And, medical errors or adverse events, to use a more polite term, are really a big issue. About 1 in every 10 hospital patients will suffer a serious adverse event. In Canada, between 11,000 and 24,000 people a year die of medical errors. It's one of the leading causes of death. And I'm not pretending all of those are preventable. They're not. But we can do a lot better. And that broad range, that's a big range, 11,000 to 24,000, it also tells us something else important, that we don't do a really good job of collecting and analyzing data. But that's a topic for another day. And people get nervous when I talk about medical errors. It's like there's an assumption I'm being critical of people delivering care, but I'm not. There's no health professional that sets out to harm people. That doesn't happen. That's called criminal activity. It happens very rarely. On the contrary, people go out of their way to not harm people. But healthcare can't and will never be risk-free. What we have to do is manage the risk and minimize it as best we can. And you do that, again, by making quality and safety your priorities. And again, I'm glad to see those words repeated over and over again in the report. Harm is rarely the result of bad medical practice. All the complaints to the College of Physicians and Surgeons, where you can make a formal complaint, 80% of their complaints are about communication. They're not about bad medical care, they're about bad communication. They're about processes, not explaining. That's why I put so much emphasis on the talking part of healthcare. And again, at the risk of repeating myself to the point of being tedious, again, what I'm saying is these are administrative and engineering problems. It's about transitions, moving people around in the right order, with the right attention paid to them, with their bracelets so they don't get lost, little things like that. Our healthcare system generally, and even individual institutions, have a lot of silos, an enormous number, and we haven't done a very good job of breaking them down. We talk a lot about interdisciplinary care, team care, but it exists more on paper than in practice. I've spoken at a lot of hospitals, I'm used to that. So Dodge Caravan, is that anybody's? Once I spoke at the hospital for sick children in Toronto, and there was a code blue and the room emptied. And I was like, oh well. I said, that kid can't be that important, stay. But I was glad they all left. They were doing their job. So all that to say, every department and every ward has its quirks and it has its culture. And some of that is good. But good management and good processes smooth over those differences and minimize the errors that happen because of those differences. What you want to do ultimately is make transitions as seamless as possible for patients. And again, it's not easy, but it's essential. And I talked about this earlier, but the other thing I liked about the strategic goals is the embracing of the concept of hospitals without walls. This notion that a lot of care has to be moved out of institutions and into the community and work in partnership with community groups. That's really what we have to do to adapt to the demographic realities of today. We have this acute care system created for the needs of people in the 1950s, and we have to adapt it to the 21st century, which is chronic care. So that's really good. And again, you can learn from other jurisdictions. New Brunswick is probably the jurisdiction that's done the most to give this concept of hospital without walls, to give it life. So, don't reinvent the wheel, I guess is the message I'm sending. Learn from others. For a long time, our provision of healthcare has been dictated, among other things, by physical facilities, what they look like and where they are. Historically, if you read the history of medicine, you'll know that hospitals have always been aloof, literally and figuratively. We always built hospitals on hills to keep sick people away from the population. We want to isolate them. We sent people to hospitals to die. And we still have those same structures, but we shouldn't have the same mentality. Hospitals shouldn't be as unwelcoming and as foreboding as they used to be. And I'm reminded this of every day because I live in Montreal, right near the Royal Victoria Hospital. It was built in 1823, and it's built right at the top of the mountain, and it looks like a creepy vampire chateau. And inside it's even worse, I can assure you. But we like to say built in 1823, not painted since. But infrastructure is a talk for another day. You guys can't complain about that here. You have a beautiful facility, even built in this century, which I can't say in many provinces. So, all this to say hospitals over time have moved closer to the people, and they've become much less frightening. But they have to keep that movement, keep it going into the community. You still have to do the acute care stuff, but you really have to supplement it a lot more. You have to break down those walls, maybe not physically, because you have a nice place here, but theoretically break down the walls and make it, again, a more seamless transition back and forth. That's what you have to do to have patient-centered care. When we talk about that term over and over again, and I think I come back to my definition. Patient-centered care is what? Safe, accessible, appropriate, affordable, respectful. All those things we have to drill into ourselves and into patients, that's what they should expect. You also have to treat people where they want to be treated, and they want to be treated first and foremost in the community where they live. I'm not saying tear down all the hospitals. I'm saying tear down some of them. But, as best we have to do is make the convenience of patients our number one guiding principle, not the convenience of providers. And we, for too long, have done that. That's, to me, what hospital without walls means. And I wish you luck, and I hope you'll make that endeavor a reality. So let me say a few words about patient-centered care, because, again, that term is bandied about a lot these days. Back in 2009, Saskatchewan actually did a whole big public inquiry about this notion. It was called the Patient First Review. The person who wrote the report, Tony Dagnoni, and if you're interested in the topic, his report is actually worth reading. It's still very current, even though it's a few years old. And he actually gave I thought, a pretty good definition, a little academic, but here's his definition. He said patient and family-centered care is about providing respectful, compassionate, culturally responsive care that meets the needs, values, cultural backgrounds, and beliefs and preferences of patients and their family members from diverse backgrounds by working collaboratively with them. It's grounded in a mutually beneficial partnership among patients, families, and providers. So that's a pretty good definition. So I think when we're going to talk about these terms, we have to be clear on what we mean. Just as importantly, in that report, he listed the ways that our current health system is not patient-centered. And sadly, even though the report is almost 6 years old now, it's still very current. So I'm going to go over those quickly. Convenience and timeliness. He said there's too much waiting and it's not easy to get in the right door for care. So it's again about moving around, about engineering. So too many people end up in the ER by default. That shouldn't be the front door of our health system. Lack of coordination. Patients do not move seamlessly through the system. There's big cracks where they fall through at transfer points, especially when they move into the community, where they need community supports. Again, it's not about medicine. A lack of equitable care. Patients want reasonable access to care, but feel they're discriminated against based on where they live, or their age, or their ethnicity, or other factors. And people in the North are particularly, I don't have to explain to you that issue about care being, I wouldn't say second rate, but different because you live in the North, and a little more different than it should be, if I could put it that way. Lack of communication and information, he said, undermines this notion of patient-centered care. When someone is sick or injured, they tend to be frightened, and they crave basic information. And too often, healthcare providers are too busy to provide it, to take the time that they should. Lack of electronic health records is still problematic. Patients hate more than anything else repeating their medical histories over and over again. And we have the technology to do it, and we just have to, again, accelerate that process. And the final one, lack of respect. All too often, patients feel like they're treated as a bother to health professionals. Patients are not cost centers, they're the actual raison d'etre for the system. And that's how we have to change our mentality and our culture. When you're using that term, patient and family-centered care, be careful of what you mean, and be careful about thinking about how we're doing it and how well or how poorly we're doing it. A lot of these challenges are about a leadership, about moving from words to action. And I want to finish on that point, the all-important point of leadership. It's often said, we hear this every single day, Canada's health system lacks leadership. And I don't believe that for a second. I don't think that's true. I think it's just one of those easy rhetorical phrases that we throw out there. They make us feel better. I think there's a lot of leadership in healthcare. Just look around you. You're all leaders in your own way. That's why you're here. And that's important. There's a lot of well-run institutions and organizations in this country. A whole bunch of them, the vast majority. But what about politicians? People say, what about the politicians? They're not leading. And I think the reality is that we can't expect them to lead. Politicians are always going to lead from behind. If they feel there's an appetite in the public and there's political gain to be had, they'll take whatever actions are necessary, however bold. But we've created this environment in Canada where they have every interest in doing very little, in being quiet. And I think that the attitude is summed up really well by an old quote. This is a quote from Joey Smallwood. He was the Premier of Newfoundland at Confederation. And he said, "I've never had a conversation about healthcare that didn't lose me votes." And that's still the reality today. That's how most politicians think. We actually reward them for saying nothing, and that's why they do nothing. So, we have to take some responsibility as individuals and as voters to say we have to create this environment to make it easier to change. That's the only way that politicians will take sustained initiative. Right now, the way we deal with problems, when problems arise, our response is what? It's to demand more bodies and to demand more money. So in other words, when something isn't working, our solution is to do more of it. And, that's not innovation, I don't think. It's certainly not leadership. Albert Einstein had actually a perfect description of that management technique. He said, insanity is doing the same thing over and over again and expecting different results. Even if you spend 2.1% more, it's still insanity, I think. I think what we need to do more than anything is focus on that structural innovation part of the puzzle, to do things fundamentally differently. So let me end by, again, talking about leadership. There's a lot of definitions of leadership. And again, it's a term we bandy about, and we're not sure what it means. So here's the definition I like. Leadership is the capacity to translate vision into reality. I think that's what leadership should be in healthcare. And that, in a nutshell, is the challenge you have, and the challenge you've set out for yourself with the strategic plan. To translate your vision into reality, to move from words to action. That's the next step. At the outset, I said your plan was refreshing. Some of it's even bold. And I think that's great, and it's necessary. The system needs to be pushed to change. It needs to be pushed from the top down, from our politicians, if they have the right environment, and it needs to be pushed from the bottom up by patients. And most of all, that demand for change has to be implemented by the people in the middle, by the providers and the administrators. And that's where you sit. The only way transformation is going to occur if all those things happen in concert. So I wish you luck doing so, and I hope you'll achieve it for the sake of your patients and for yourselves, because it'll make a better work environment. And if you have any questions, comments, I'd be happy to listen to them now or afterwards if you're shy, whatever amount of time we have. So thanks for your attention.